Very excited for this session today. Um, as you guys know, I'm Anna Luker. I'm one of the peds hospitalists at Kapiolani and co-direct this echo, and I'll be manning the chat. So if anyone has any questions, you can always unmute yourself and feel free to join the conversation, but otherwise, any questions can go into the chat, and I'll probably save them for the end unless it's urgent. You can just add that as well. And then I will pass it on to Dr. Phelps Nishiguchi. I'm very, very excited.
All right, thank you. You know, it kind of lowers the intimidation to have a small group anyway. So let's see, share my screen. Showing up for me, so I thought you guys could see. Now you see my screen? Okay. So I titled this presentation, Hurry Up and Wait, because there's so much emphasis on early diagnosis, screening, surveillance, get kids in for early intervention. And so there's been this huge effort to get kids identified, and then they end up on our wait list. And it can be a very long time before they are seen by us or other diagnosing providers. And so I was hoping today to talk about some of the ways that you all as primary care providers can support the child with suspected or sometimes known autism while they are on our wait list. I don't have any disclosures. And I wanted to start off by just briefly introducing myself because I'm new to the community, to Hawaii, and I'm hoping to get to know more people. Very excited to come and meet you all through ECHO, and hopefully I'll be able to attend more sessions and participate more as I continue to get my feet set. I joined HPH about a year and a bit ago, and then I was out on maternity leave 7 months in. And so I am very passionate, actually, and very interested in rural health. I grew up in rural communities in Tennessee and Uganda, and I was very interested throughout my medical training to focus on rural needs, rural health needs. I married a Japanese guy. We kept moving further west, and Hawaii was very attractive to us because of the dual heritage, but also, or the multi-heritage, but also multicultural community that has a lot of aspects of rural health, some very unique aspects with the fact that we have the whole Pacific Rim communities and also areas of water in between. So it's much harder, especially for developmental behavioral kids, to get in on a plane and come see us versus just driving in a car. And also my interest in global health, there's a lot of ability here. So Hawaii seemed like a really excellent place for us to come and set down roots and grow our ohana. I also have a lot of clinical and research interest in interdisciplinary and collaborative care, and working with community engaged research to focus on interventions that are realistic and relevant to the communities that we serve. And so that's one of my draws to being part of ECHO, is to try to get to know you all better, know what would be helpful for you all in supporting our shared patients, and just letting you know that I'm very open to collaboration and working closely with you. I also am very passionate about multi-level advocacy for systemic change for our patients. We all know that there are a lot of barriers to care on many different levels for our patients. And then in fellowship, I started to get a bit of an interest in medical education because I saw that as a path for how we can better support our patients, because there's such a dearth of developmental behavioral pediatricians. We are never going to be able to see all the patients. And so I think medical education is going to be one of our main tools for supporting the patient population. So that's me and my family. Today's learning objectives, we'll talk about some comorbidities and how to plan additional referrals and therapies to other aspects of care. And then one thing I really want to focus on is how we can help families, how you all can help families with accessing ABA services, which is one of the primary evidence-based interventions for kids with autism, as you know, and early intervention really makes a difference. And then I want to think about how the chronic care model may support children with suspected or known autism. I'm going to start off with a case. This case was, it was one of my very first patients as a fellow. I met her on Halloween. She was dressed up as a cat. And I started my continuity clinic and fellowship just after boards. So, this was probably 1 or 2 weeks into my continuity clinic, and she made this huge impression on me. And I hope that her story will also make an impression on you. So she's a 6-year-old female. She was referred for developmental delays. And when I went in and did her chart review, I saw that she had a term birth that was uncomplicated. And she immigrated to the US about a year ago and got on our wait list immediately. She has delays in many developmental domains: cognitive, language, social, emotional, adaptive. So I'm thinking she's probably being referred to us for concern for suspected autism. She also has a history of cortical dysplasia and epilepsy, but she has already been seen by neurology. And our local neurology team has questioned that diagnosis and actually repeated her MRI and EEG, and these were normal. And they're actually weaning her AEDs. She has a diagnosis of ADHD and is on a small dose, the 5 milligram methylphenidate immediate release daily, just the one dose. And then somewhere on our problem list was this mention of constipation, but there's been no documentation of any care for constipation lately. So when I went in the room and asked what the family's goals were for the visit, what I wanted to talk about, they were very concerned that her development is regressing. She's not eating well. She has a new difficulty with using utensils. She is requiring assistance with toileting and having accidents, whereas previously she was toilet trained and independent, and she's having progressive aggressive behaviors. So my thought very quickly changed for this patient. I walk in and thinking this is a standard, autism evaluation, and here is developmental regression, which is one of the only real urgent emergencies in developmental behavioral pediatrics. So to get a little bit more information on her, I learned that she has constitutional poor growth, but her parents are concerned about her weight. They're feeling like she has not gained weight since moving here. She is refusing to eat many foods. She's always been a picky eater, but now she's been refusing more foods, especially in the last 7 months, and supposedly is only eating chips in the last 3 months. She used to drink milk, but now she's refusing her milk too and any other fluids except for water and some occasional soda. She's having difficulty using utensils. She appears weak. She used to have no problem, but now she's dropping food as it approaches her mouth, and she's developed a tremor. So it's like this tremor is causing a problem plus the weakness. And she's also having difficulty with other fine motor skills, such as and adaptive skills, such as dressing herself, whereas previously she was independent. She's having this toileting regression. Previously, she was toilet trained with both urine and bowel, and now she's having enuresis and encopresis at home and at school, so across settings. And apparently this began before she moved to the US, and it's been progressively worsening for this whole year. Aggressive behaviors and crying outbursts, these have been a part of her since infancy, but they have been worsening as she aged. There's a little bit of some improvement when she first started the methylphenidate, but really that's been more helpful for her focus and attention. And it hasn't helped these behaviors, and these behaviors have been getting worse over time too. There wasn't any specific uptick in her behavior with the move a year ago, but it has been progressively getting worse ever since. Interestingly, she's not aggressive towards her dad, but she is aggressive towards her mom, her siblings, and school teachers, aides, and peers. This is her growth trajectory. She is not at all on the curve, and she is flatlined with her weight. So very concerning. Her exam was very concerning as well. She has dysmorphic facial features. She was hyperextensible in multiple joints. She had a mild pectus. She, I forgot to put it on here, but she has a murmur, grade 2 or 3. I think it was grade 2. And her abdomen was soft and non-tender, but there was palpable stool in the left lower quadrant. Her neuro exam was pertinent for being hypotonic and quite weak diffusely with diminished muscle mass. She had brisk reflexes. She had these tremors and jerky movements throughout the examination, and she was dysmetric on her nose to nose. She stood unsteadily. She had a bit of an ataxic gait. It was a bit wide base, so she was very unsteady. She did not feel comfortable. She refused to bend forward because she really started to lose her balance. And she wasn't able to do the heel to toe walk and did not walk on her toes, which can also be a sign of the weakness. So my plan was, let's do an urgent workup for metabolic concerns in the setting of all this developmental regression. And then I'm also interested in her general history of global developmental delay and her dysmorphology. Her metabolic labs, which included all the urgent ones, plus we redid the newborn screening for her since she was not born in our country. Everything was fine. We went ahead and did audiology because she had this speech and language delay, and it found that she had bilateral profound hearing loss. And so we referred her to ENT. Because of her murmur and this hyperextensibility, we were concerned for connective tissue disorder. So we went ahead and did a screening echo and renal ultrasound. And that was notable for bicuspid aortic valve. So we sent her off to cardiology. She was already seen by neuro by one of my co-fellows, and so I had already talked with neuro on the phone, and they were able to get her in quote unquote urgently in a month. And at that point, her symptoms had resolved, and everything looked fine. And I got to tell you that as very early fellow, having this patient, and then 1 month later she's seen by neuro, and they're like, I don't see anything that you saw. Definitely made my imposter syndrome kind of flare. But they did agree with her dysmorphic features and interesting picture and wanted to proceed with genetic testing. The other thing that we did for her is that we thought about her existing medical comorbidities and other things that might be contributing to her presentation. So with appetite suppression, we wanted to decrease or stop her stimulants, but her parents said that she immediately had out of control behavior at school and home, and so she actually remained at her dose. And then I did a GI clean out for chronic constipation. If I've had any of your patients, you've probably seen me strongly recommend this for many families that come across my desk. When I saw her in follow-up, her parents said that they did the stool clean out and she immediately began to eat after that complete clean out, and she had improvement in all of her acute symptoms. And this was her weight. Sorry, it shows up so weird, but you can see that she was plummeting and then had really flatlined, right? And then now just with a bowel clean out, an outpatient one, she suddenly was able to gain weight and again had this remarkable recovery in her symptoms. So when we think about how that all ties together, her not eating well was decreased appetite from abdominal fullness that was just getting worse and worse. She had acute malnutrition, and this was affecting her energy, which was affecting her weakness and her causing this tremor. The constipation itself was causing toileting regression. And then the aggressive behaviors, this is behavioral sequelae of abdominal pain and also the acute malnutrition. And in retrospect, we really should have believed the fact that she was only eating chips and had probably admitted her for concern for potential refeeding, but we thought there was much other things going on. And so fortunately, she was okay and had a remarkable recovery. So that was just to set the tone. Now we'll move on to talking about the waitlist here and now and what you all as primary care can do to support patients and families in addition to referring to us. So daily life for almost all patients who I see in clinic is greatly affected, usually by some element of sleep, nutrition, elimination, behavior, stress, or all of the above, affecting the whole family's quality of life. It's really hard for the kid, but it's really hard for the family too. That includes the parents, the siblings, extended family members. And when we're thinking about these kids in the medical home setting, like these are things that don't always need specialty attention. At least we can get started with supporting them on some of this journey. I think that diagnosis for autism or other neurodevelopmental disabilities can provide a lens, and it opens some therapeutic services, but most of where I feel like I'm making a difference in patients' lives is with taking the time to talk with them about these things. And I do recognize that I have the benefit of time, but my hope is that some of this conversation can happen before they cross my threshold. So a case that is very representative of a lot of cases that I've had in clinics since starting here is a 4-year-old kid who's been on the wait list for 2 years. When I first started, I had a lot of kids who'd been on our wait list 3 years. So we've gotten it down to 12 to 18 months now, but that's still a very, very long time. This kid was actually diagnosed with autism through early intervention. So early intervention, the Department of Health contracts psychologists for some of these kids, and they do an assessment. And the diagnosis was autism with language impairment and associated global developmental delays. And they had their 2-year-old wild child check where the PCP mentioned that they were diagnosed with autism, that they are appropriately with early intervention, referred to Dr. Okamoto, and then return in 1 year. And then at the 3-year wild child check, family hasn't heard from DBP yet. They did return our forms. FYI, I don't require those forms. I know that that's a huge barrier for a lot of my patients. And so I just want you all to be aware of that if that's been a hindrance to sending anyone my way. And then the PCP mentioned that they're enrolled in SPED, mentioned something about constipation, discussed Miralax, and then return in 1 year. And then I saw them. And at our new visit, the parents said that their goals are that they really want ABA. They've been trying to get ABA, but they heard that they had to wait until the DBP appointment to be able to get ABA prescribed. At least for the medical diagnosis for insurance for medical to cover. For the HMP, these parents did bring the prior autism diagnostic report. A lot of times they don't have it or they don't know where to get it. But this family did bring it, and I was able to review it and saw that it was this clinical psychologist contracted by DOH, and she had completed the gold standard behavioral observation, or ADOS test. And she is in SPED, and her IEP eligibility category is autism. Review of systems with the family uncovered a restricted diet and picky eating, very, very common in our patients. Sleep issues, she gets in bed around 11. She has frequent awakenings, and then she's up very early in the morning for the day, like 4. Constipation, she's been taking the Miralax every day, but it's not helping. And then behavior, she's having aggression and tantrums. So what can be done in this case? Like, you guys have 15 minutes, maybe, and there's a lot. So some of the things, and maybe it needs to be, okay, 15 minutes now, come back and follow up for another 15 minutes. I don't know how possible that is for you all, but some of the things would be like many of you are appropriately checking in and making sure that they're enrolled in early intervention or school, and that's wonderful. In the other states that I've worked in, that's not always been the case. So I'm so pleased that so many of these kids, even if they're not getting into us, they've already started getting the services that the government provides. You can confirm the diagnosis in the medical record, and we'll talk about how to do that. And then we'll talk about some of the additional referrals that might be helpful so that you can get those going versus waiting for my assessment and getting them on those wait lists at that point. We'll talk about how you all can be empowered to recommend ABA and other therapeutic services. And then some of the assessment, treatment, and referral for comorbidities. Actually, I'm not going to have enough time to go through those in detail, but they are available in the slide deck just for thoughts from the DBP perspective. And then we'll talk about some of the supportive services. There's a lot of really helpful supportive services, and you probably know them in your community, and I would love to hear which ones you send your families to, so that I can be aware of them too. I'm still getting to know everything about Hawaii and our communities. And then yeah, for the 15-minute problem, I really think that the chronic care model can be helpful in the pediatric medical home. And so if this is something that's hard to initiate for whatever reason, in our care centers, I would love to hear about that. Thinking back to my advocacy lens and research lens, like what are some of the things that we can do to reduce those barriers if there are barriers? So thinking about supporting enrollment in early intervention or the Department of Education. So as you all know, birth to 2 years, 11 months is through early intervention. And then 3 to the 22nd birthday is the Department of Health, Department of Education. Common concerns, so even when families have discussed this with the pediatrician or the primary care, and I see that it's been mentioned in their well child checks, families often say to me like, oh, well, we stopped early intervention because of the pandemic, because it's virtual, they're not working directly with my child. And so a lot of families are not understanding the coaching model that early intervention is using. And so sometimes just spending a little bit of extra time to explain to them like the coaching, that this is not an individual therapeutic model. So I don't want them to expect that it really is empowering the parent to, because they're the ones that are with the kids all the time, to know the skills to help support them. Still, a lot of families may elect not to use it, but I find that when families kind of understand where the model is coming from, sometimes they'll be a little bit more receptive. A lot of families tell me that they talked about attending school with their PCP, but they didn't move forward because their kid isn't toilet trained yet, and so they don't realize that that's not a barrier when your kid has a disability and has an IEP. A lot of families are very concerned that they can't even control the behavior at home. How is school supposed to help with the behavior? And behavior support is one of the primary things that the IEP can help with. And so really emphasizing that can be helpful for families. And then this was a little trickier. I don't want my kid picking up on other poor behaviors when my kid just has a language impairment or something as mild, some social skills challenges. It's like, well, I don't want those things to get worse by picking up on other kids' behaviors. And that's where we can emphasize that the IEP should be delivered in the least restrictive environment. And that includes general education, even in the special education setting. Not all schools have a head start on their campus, but it's the school's responsibility to help figure out how do we get the services for these kids in the least restrictive and appropriate environment for kids. And so we don't want that to be a barrier. So diagnosis, so I've worked as a DVP in Washington State and Ohio, and in both of those places, it was much harder for a general pediatrician's note to matter for ABA to even count for diagnosis in many cases. But I was pleasantly surprised to learn that in Hawaii, that general pediatricians do count as diagnosing providers, and other practitioners with specialized expertise can also count. And so if this is something that I think lowers the barrier in terms of what can be done in primary care to help support our kids, especially since we have these other modes of diagnosis, like through psychologists. I think it's also important to know that, I think most of you know that psychologists and psychiatrists can also diagnose. So a lot of times I see referrals going out to Sakura Center, LD ADHD Center, and some of these other places too. So the IEP eligibility category of autism spectrum is not a medical diagnosis. I think you all know that, but the DOE contracted psychologist through early intervention often completes a complete diagnostic assessment. And a lot of times I've seen the DOE has even contracted a psychology center at UH or some other place to conduct full diagnostic assessments. So a lot of times a full diagnostic assessment really is happening. And this is where we look for the DSM-5 criteria to have been addressed, and that some standardized behavioral assessment has also been done. And most commonly in our state, there's the ADOS-2 and the CARS-2, but there's other behavioral assessments too. So when someone comes in and they say that they've already had their diagnosis, either here in Hawaii or coming from the mainland, you can take a look for these elements, the DSM-5 criteria and the ADOS assessment. If you write it in the medical report and reference it in the medical record, that should be enough. A lot of times when kids have already had their had a diagnosis and I get the records, this is what I'm doing. I'm not going and doing a whole nother assessment for them. I am looking at what's been done, documenting what's been done, and then adding my own pertinent positives or negatives in the physical exam observation section. And so because primary care, general pediatricians at least, are diagnosing providers, you all could use some kind of text like this, which is very similar to what I write when a kid already has a diagnosis. So this person was diagnosed with autism by whom, on date, and then including the DSM criteria, and then standardized behavioral assessment using, I name the instrument, and then I say wherever it is that the notes are. I have time most of the time to include some of that information in my note, but it should be enough if you have it in the medical record to direct to the space in the medical record. And then I have a smart phrase, and I've shared a lot of smart phrases with you at the end of the presentation of the short DSM criteria and whether yes or no. And so for DSM, the 3 social relationship A criteria must be met, and then 2 of the 4 restrictive and repetitive behaviors must be met either now or in the past. And then if you don't have a diagnosis, but you strongly suspect or you know that they have autism, but you don't have the time to be able to do the full assessment, you can write, and I've seen some pediatricians writing this, I strongly suspect child meets the DSM-5 criteria for autism, and they've been referred to whomever diagnosing entity for diagnostic assessment. And in this note, you can write the DSM-5 criteria, again with a smart phrase or a table, and say why you suspect it. And again, back it up with your observations on your physical exam. And this matters for insurance accepting this strong suspicion, some of our insurances. We'll talk about ABA in a moment, but some of the additional referrals that can be helpful, and this comes from the AAP clinical report in 2020. All kids should be getting a developmental assessment of the rest of their developmental domains, including cognitive, adaptive, and language. And usually the schools are doing this they should be, as part of their psychoeducational evaluation to determine eligibility for the IEP. And actually these are the assessments that I look for and use. I do screening, and we do screening in our developmental clinic. We are not resourced enough to be doing full diagnostic assessment in our clinic anyway, and it's already happening in the school. So you all can look potentially for that too. And then of course the private centers can also be helpful. There's a form that I think most of you probably know about, asking for a developmental assessment, and you can ask specifically for these 3 items and anything else that you're worried about, and have the family take that to the school. The school does not have to do all of what we recommend, but it's strongly encouraged from our end, and that can help back up whatever a parent is saying. And if we send our medical records with a parent permission, sometimes that can help get across what we're saying, because I've had a number of families who take my form and then they're meeting with the school and the way that the school is asking the questions, the parents answer in a way that the school's like, well, I don't see what the problem is. And then I get on the phone with the school. So I think I've started asking families to take my note with them. Audiology, all children with language delay should have an audiology assessment. And it can also be really helpful for kids with significant articulation difficulties, especially if it's affecting intelligibility. Of course, there are some articulation differences that can persist up to 8, 9 years old, but a kid by 4 years old should be 100% intelligible, even around their articulation challenges. So if you're having a difficulty understanding a kid, we should get them into audiology. I've had a couple of kids diagnosed with even just unilateral hearing loss just in the last year. Vision assessment is strongly recommended, including pediatric ophthalmology, because they can do the measurements rather than asking for a kid to become, responsive to an eye test. To be honest, I'm not always sending my kids for vision assessments because it's been a lot harder to get kids into. But certainly if you see very significant stereotypic behaviors, such as like close inspection, really looking closely, or doing the side gaze kind of thing, or eye poking, all of those things can be sensory part of autism, but they can also be a sign that, I'm not seeing things very clearly. Technically, the AAP recommends the vision assessment if you're visually inattentive or not making eye contact, but those are core features of autism in general. And so that would be every single one of my patients. But certainly if you see kids with concerns, sending them to ophthalmology beforehand. A sensory processing assessment is now considered an important part of standard of care. And this is part of an occupational therapy evaluation. And many times the occupational therapist can do this at school. So it doesn't have to be a private referral. But we have to make the case for how that's impacting access to education. And oftentimes sensory integration challenges are affecting the behaviors, and that is how it is affecting access to education. And then confirmed or highly, if you have a confirmed diagnosis or you're highly suspicious of autism or intellectual disability, go ahead and refer them to genetics. I know we've been in and out with genetics provider, but our current geneticist, Dr. Huffnagel, wants to see all of our patients without us doing the first line testing anyway. And so we can skip an additional waiting moment if you guys go ahead and put in that referral at the get-go. And this is the way that we explain it to families, right, is that it's helpful for understanding recurrence risk, but for the patient, it is really helpful because if we understand what specific is different, causing the differences in their brain, we can understand if other people with that difference have other parts of their body that are affected and other medical comorbidities that we should be monitoring for. Okay, so applied behavioral analysis referral. So ABA assesses and modifies behavior through intensive one-on-one therapy. It increases functional skills and it helps reduce interfering behaviors. Usually it's at least 15 hours a week, so it's very intensive. It can be up to 40 hours a week. And we should be asking our parents and helping our parents understand that they can get parent caregiver training and support for 1 hour, usually every 2 weeks or once a month. And this is true even if they're getting DOE-based ABA services. Delivery of Put Center Home and Community, that's a private ABA. In Hawaii, we're also really lucky to have ABA in the school. And I think this is a wonderful gift that our DOE has, even though there are challenges, because it helps reduce some of the profound inequities with ABA access. I could not get this for my kids in Washington or in Ohio. So it's really nice that we have that here. But not everyone can get it, unfortunately. So a lot of times we want to ask for ABA in the private setting too, especially for the young kids. So if you have documented diagnosis or suspicion of diagnosis, then medical should cover. as long as you've included the points that we mentioned before, the DSM criteria and the assessment used. And then it's helpful to include a description of medical necessity. So that's in my dot phrase list at the end too. And then specify some specific targeted behaviors. The ABA team, when they do their assessment, they will ultimately come up with the goals, but having some specific behaviors that you mention in your note can help flag it for the medical, so it doesn't automatically get rejected for being non-specific. Because as one peer-to-peer that I've already done said, anyone can benefit from ABA. So if you're just doing it as a reflexive, then we're not going to accept it. And yes, suspicion of diagnosis counts. And Dr. Okamoto pointed me to Luke's Law, but when I actually read Luke's Law, I don't think it's there. But I did find the MedQuest memo in 2017 specifies both that general pediatrician count as diagnosing provider, and this quote that because of the complex nature of diagnosing, recognizing our long wait list, if there is strong suspicion, then the child can be qualified for up to a 26-week trial of ABA. So they can get up to 6 months of ABA treatment even before they've come to us. And so this could be really helpful for families. And if they continue to see you and they come back and you document continued difficulties or interfering behaviors or need for functional skills, there's a clause also that this trial may be increased, although Dr. Okamoto's only seen it get to the 6 months. And this matters because early intervention matters for our kids. And so I hope that the material that I provided today help you be able to take advantage of this clause that we have, at least for our MedQuest patients. I have run into more challenges with some of the private insurances, but I think it's still worth a try. These are the major comorbidities. I touched on them earlier. I don't have time because I wanted to make sure that we have time for questions and answers to go through them in detail. But I've included, like these are the ones that I make sure I touch on in my visits, at least, because these are the ones that impact stress and family stress, quality of life, and they don't have to wait for me to be able to be discussed. Each of these slides kind of talks about some of the things that I think about from the DBP perspective and some of the referrals. Nutrition is huge. Lots of different things that go into nutrition. Elimination is huge. I always use the Bristol stool chart because if you ask someone if they have constipation, most of the time they'll say no. And then you hand them this picture, you bring it up on the computer, and they point to type 1 or type 2. I'm like, huh, okay, we can help with this. Safety is huge, 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 huge. There are some national resources. This is something that takes a village to really help our families with, but at least if we can help point them in the right direction and get them some resources, they don't feel like they're walking this alone. And speaking of not walking alone, getting family support is really, really important. So every state has a family-to-family information center, and ours is Hilopa'a. And so at the very least, I want families to know about this organization and our Special Parent Information Network, which is a huge resource. And they have collated all sorts of resources on their website, and they send out a monthly newsletter. They have regular e-blast, and they have an annual conference with workshops, and it includes stipends or scholarships for families from other islands to attend. And lots of our families have really liked attending this. And so they don't have to come and see us before they start tapping into these services. I would love to hear from you about the community support networks in your community so I can make sure that families are tapping in. And then I always want to encourage kids to be getting their physical activity, and there's many different options. All of our kids should be able to join regular options with some accommodations, but some families don't feel comfortable. So there are some organizations out there, and one specific to autism is Never Quit Dreaming that a lot of my families have really liked. Again, it's too much to cover in 15 minutes, I realize. So I want to know from you all, like, if you can't see them back in follow-up, like, what are the barriers there? How can we try to address that? Is it possible to come back, like, in a chronic care model, like every 3 months or so, and kind of tackle this one step at a time? Can we problem solve functions of behavior? That's a whole nother talk. So many families just feel so alone with this. And so I'm hoping that more increased touch points with the medical home can help them feel like, okay, we're being cared for even while we're on this wait list. And then I have started, just because of my own limitations and needing to try to see more kids on the wait list, is for some of these primary care-esque problems, even though I get more time to talk through it, I'd like to send back to the primary care home for, like, following up on constipation management, bowel clean out and that kind of thing. But I also want to know if that's a burden. So I have references, some additional resources here. And then there's a QR code with my smart phrase, and you guys should all have access to my slide deck here. Please reach out to me. That's my HPH email. I also respond to chats and in-basket messages. Sometimes I'm not the most prompt at responding to, but I do my best to respond to them when I get to them. So thank you.
Thank you so much. I'm very impressed with all the information you managed to pack into this talk. There's a lot of very, very useful links in there, and just generally useful information. As I'm talking, starting to read through questions. Sorry, there are a few. And then do we, I don't know, Summer, do we want to do questions as well at some point?
I can run the poll if no one else has questions. I saw a couple questions in the chat.
Yeah, and we can get started with those. I'm going to go in reverse order. For the ABA trial through MedQuest, what kind of documentation is needed to access the service, and what is the process?
So this is the documentation that's needed. So the DSM-5 criteria must have met all 3 and at least 2 of the B criteria, and then documenting the use of that standardized behavioral assessment, and then including your own clinician observation. Usually in the physical exam, you can write behavioral observations. And then this is the text that I use. And then for the ABA, like medical necessity, I have a dot phrase for that in the dot phrase in the Google document. I didn't put that in a slide, sorry. What is the process? So I give the family the report, or at least a letter of diagnosis, and the medical necessity, and ask them to contact ABA companies. If we have a list in our office of which ABA companies take which insurance, but if you don't have such a resource, you can ask them to contact their insurance. Their insurance will know which ABA providers take their insurance, and then they will ask for that documentation. And then it is a crazy long wait list, like 2-3 year wait list. Sometimes for our young kids, they get in sooner because they will sometimes do it instead of DOE. I don't like that. I like to do a hybrid at least, where they're getting 2 days of the services through the DOE because they're getting speech, occupational, fine motor, exposure to other peers. But I do think that the more intense AAP in the young kids can be really helpful. ABA can be helpful in the young kids. So this is another reason that I think primary care being able to do this will be really helpful, because families are so crushed when they come to us, and then we put them on another wait list because so many families think that they're going to get that service through us, and we don't have that, unfortunately. Can a smart phrase? Oh yes. Okay, let me get back to that. There. Rochelle, did I answer that question appropriately?
I don't hear otherwise, so I think so. While we're waiting for more questions to come through, maybe we can go over the poll. Perfect. I always want to start the like Jeopardy music.
Oh, and I'm going to
people are
say,
doing their poll
because
questions.
so many people came in after my little introduction slide, that I have a real interest in rural health and how to support our families through collaboration and research. I'm also part of our LEND team, Leadership, Education, and Neurodevelopmental Disabilities, where we do a lot of community outreach. And so I am very open to hearing from you all about what our patients need, what you guys need, and doing my best to try to facilitate that. I want to start coming to some of the other islands. Dr. O does a Hilo clinic now. The plan is for me to do a Hilo or a Kona clinic and maybe a Maui clinic. That has been postponed due to my baby, but we are hoping to start that next year and slowly percolate. That was one of my main goals in coming to this community, is I really want to give direct access to our care and not only through telehealth. But making that happen is sometimes hard.
It is, and I find, it's such a different and unique challenge having ocean between our islands, our state just being as spread out as it is in that sense, right?
Yeah. Like I did a residency and fellowship in Seattle with our WAMI region. And people would complain about a 2-hour car ride. I'm like, okay, you didn't have to get on a plane.
Exactly.
It sucks to have to drive too. And that is just another layer of access difficulty.
Summer, how much time should we give people?
We have about half, so maybe another minute or so. And everyone, maybe the last question we'd have to review. That's the only one. Wide.
That's a poorly written question, isn't it? So sleep, naturopathic, GI, all of those are based on our assessment for any concern. But genetics is one. Any child with a diagnosis of autism or intellectual disability, standard of care is to get a referral to genetics to look for the underlying genetic cause to help with understanding additional medical risk unique to their genetic difference, if we find one, and recurrence risk, and for siblings. GI sleep, a lot of that can be done in primary care. But if you're running into problems, then you can certainly send on. I've sent on a number of kids to ENT, for example, because they have significant sleep disruption. They're snoring a lot. I look in, they have tonsillar hypertrophy and it's persistent. And then I've had a couple kids get TNAs already in the last year, and a couple who are doing conservative management, but that can make a huge difference in behavior too, if kids get better sleep. Naturopathic medicine, definitely not standard of care, but many families want to explore it. And so I talk about risks and benefits of some of the non-evidence-based care out there, but a lot of times there are some, they really take some time to go through nutrition and everything. I don't think that's a bad thing for our kids. So
and I think the other ones were almost 100% correct.
Yep.
I should have capitalized the not probably for the no, actually
No, no, no. You're keeping us on our toes as the lunch hour is nearing its end.
Yeah.
Does anyone have any more questions? Oh, here we go. So one just came in. I have a member that is not autistic. Oh no, my chat moved.
Okay.
mid-reading it.
Spastic diplegic cerebral palsy. Do you know any resources for this diagnosis? Yes. I guess medically, physiatry is really important, and we do have a new physiatrist who's coming on board starting in August, which is very exciting. Just finished her fellowship in Cincinnati. Might have been Columbus, Ohio somewhere, and she's very, very passionate. Behavior wise, education wise, I'm happy to see these kids too. There are, I guess it depends on what resources, like in terms of connecting with other families, Spin is still a really great resource. I love the CP channel for kids and families with CP. It has a lot of really great disability affirming, helpful resources. The CP channel is a website and an app. Stool problem, do I feel that stool problems result in nutritional problems which are then made evident behaviorally, or is there some other expression involved? So stool problems are usually from a poor diet to begin with. These kids tend to have very restricted diets, usually very processed diets devoid of fruit and vegetables and all the fiber. And so a lot of times we see nutrition affecting constipation, then feedback causing discomfort, behavior, all of that, and sometimes, like in my case, reduced, further restricted diet. There's some thought potentially that because we don't fully understand the microbiome and the gut-brain connection, but there may be some underlying differences for some of our kids that impacts their GI motility or their risk for constipations, but most of the time our kids have the restricted diet, and that's the primary issue. These kids tend to be on Miralax or other supports for a very long time. So I wrote in here the website and app is CP channel. I also love the Can Child materials. And this is for any kid with a disability, but it was created for CP initially in the F words. Very disability affirming, supportive approach to kids. And thinking about the F words are family, function, fun, friends, future, like these other things that we should be always thinking about with a strengths-based approach for our kids with disabilities. And this is a nice way to think about it and approach it. Thank you all so much. It's fun to be part of ECHO. I'm sorry that we had all these connection issues. I'll definitely make sure that I come back.
Thank you, Dr. Phelps Nishiguchi. That was awesome. I just wanted to mention next session on July 3rd, we have Dr. Candy George. I lost where I put it.
I think she's going to be talking about prenatal and NICU palliative care.
Thank you. Mary, now I did receive an email from you and I was not able to open it. It's secure, and when I open it, it's like it's coded and I can't read it. Renata, I'm so sorry you're experiencing these issues. I don't think anyone else reported connectivity issues today or getting kicked out. So I'm sorry you're going through that. I think it's a unique issue for you and maybe on your end. we weren't intentionally dropping you, so I'm sorry you were experiencing that. There's a nice message for you in the chat from Rachel. And mahalo everyone for joining us. Thank you.
Hi, thank you, everyone.
I'll give Dr. Phelps Nishiguchi some time to read. That's a nice long, long.
Yeah, very nice. Yeah. Yeah, affirming the need to have these touch points and really understand the immense anxiety, frustration, disappointment, stress that these wait lists cause. And yeah, even discussing the suspicion of autism is hard. I will say that with social change and more acceptance of neurodivergence and disability in general, that I'm seeing fewer tears, even for people who are. I mean, a lot of people I'm seeing now have been preparing themselves for 2 years for this diagnosis. I still see a lot of tears, but I think in general, even just over the course of my fellowship, I saw more acceptance of the diagnosis and helping their kids rather than really treating it as truly bad news situation, which is how I was initially trained. Like, we should treat this as a bad news conversation.
Okay, mahalo everybody.